My first day in the Cath Lab taught me one of the most important lessons about emergency cardiac imaging. It started as a routine case until it wasn't. The patient was on the table when things went south. My tech, fresh from working on the echo floor, instinctively tried to get a parasternal long-axis view, just like we always do upstairs. But this was different. The patient was flat, draped, and the chest was prepped for the procedure. I wanted to scream, "You can't get those windows here." Precious seconds ticked by as they struggled with the impossible, trying to get apical views, parasternal views, any of our usual go-to positions. But with the sterile field and patient position, it was like trying to see through a brick wall. The team was asking about fluid, about tamponade, about cardiac function, and there we were, dancing around the obvious solution. Finally, someone called out, "Go subcostal." But it was too late. Those wasted moments trying for traditional windows cost us valuable time. The patient didn't make it, and I learned that in the Cath Lab, rules are different. Subcostal is your lifeline. It's your first and sometimes only window to assess for fluid, tamponade, and cardiac function. Now, whenever I'm in the Cath Lab and there's an emergency, I practically vibrate with the urge to remind them. Skip the usual views, go straight subcostal, because in an emergency, especially in the Cath Lab, your job isn't to get perfect images. It's to quickly assess for fluid and function. And sometimes that means throwing the regular rule book out the window.